So here we are going to talk about the abdominal wall defect, particularly omphalocele and gastro cases. So first one is congenital defect of abdominal wall at or near the umbilicus, allowing for herniation of abdominal organ. So let me explain here. So gastro cases or omphalocele, what say? The intestine are outside the abdomen through a hole in abdomen. So this is the abdominal content. Gastrocases. The gastrocases is a birth defect in which the infant's intestine are outside the body because of hole in abdominal wall. It is the abdominal wall defect. And omphalocele, the intestine, liver, or other organ remain outside the abdomen in a sac. But here, there are no sac. So if I compare and contrast gastro cases or omphalocele, gastro cases occur to the right of umbilicus and hence extruded bowel that in uncover. But omphalocele is herniation of abdominal content in the base of umbilical cord, so the content are covered. And omphalocele is associated with other congenital defect, while gastrocases is not. Let me go back in my first page. Omphalocele occur when there is a herniation of abdominal content through the umbilical ring, usually with an intact peritoneal sac. So the basic pathology for omphalocele, umbilical ring defect with herniation of abdominal organ covered with peritoneum, like this picture. The protrusion covered by a translucent sac that may contain bowel or other abdominal organ. So omphalocele, immediately after the birth, the sac is covered with a sterile gauze soaked in normal saline to prevent drying of abdominal content. So a layer of plastic wrap is placed over the gauze to provide additional protections against moisture loss. Rupture of sac result in the evisceration of abdominal content. Once the infant is stabilized, synthetic materials is used to cover the intestine. Monitor the vital sign every 2 to 4 hours, and temperature is particularly important because infant can lose heat through the sac. Preoperatively, maintain nothing by mouth status. IV fluid will be prescribed to maintain hydration and electrolyte balance. Monitor for sign of infection and handle the infant carefully to prevent the rupture of the sac. And post-operatively, control the pain, prevent the infection, maintain the fluid and electrolyte balance, and ensure adequate nutrition. And gastro cases, basically, abdominal wall defect to the right of umbilicus with herniation. So you can see this came out, herniation, and no peritoneal protection of the content. So there are no peritoneal covering. So occur when herniation of intestine is lateral to umbilical ring. There are no membrane cover the exposed bowel. The exposed bowel is covered loosely in a sinusoid, and also abdomen is loosely wrapped with a plastic wrap or bowel bag. The wrapping directly around exposed bowel is contraindicated because if the exposed bowel expand, wrapping could cause fissure and necrosis. So both case a protruding sac or organ. If you go check for lab work or diagnosis, prenatal ultrasound can help. Clinical examination can help. The preoperative, postoperative. So the management is surgical closure of defect. IV fluid, electrolyte balance is important, antibiotic important, and nursing care plan. So place the lower half of intestine in infant in clear, sterile plastic bowel bag because it provides protection, also visualizations, and decrease the heat and moisture loss, right? And what preoperative care is similar there for omphalocele. Surgery is performed within 7 hours after birth because no membrane is covered the sac. Postoperatively, most infants develop prolonged hilators and require mechanical ventilations and need parenteral nutrition. Otherwise, care is similar to that of omphalocele. So, if any complication cause short bowel syndrome developed, also necrotized enterocolitis, the complication in both cases.